All right, let's talk about clavicle fractures. If you're getting ready for your orthopedic exams, you know this is a topic that's almost guaranteed to come up. So in this explainer, we are going to break down exactly what you need to know to nail your Viva answer with confidence. Okay, let's get right into it.
So why do we care so much about this one bone? Well, because they're incredibly common. Clavicle fractures make up a massive 10% of all fractures. You're going to see them all the time, and you're definitely going to be asked about them.
Here's our game plan. We'll start with the basics, who gets these and why, then we'll cover how to classify them using the Allman system. We'll dive into the big treatment debate, to operate or not, and we'll really focus in on those tricky, displaced midshaft fractures. After that, we'll arm you with the landmark studies you have to know, and we'll wrap it all up with a classic Viva scenario to make sure you're ready.
Okay, first things first. Let's talk about the epidemiology and mechanism. You know, who gets these fractures and how does it happen? Getting this context right is the first step in your assessment.
When you think about who gets these, picture two completely different groups of people. It's what we call a bimodal distribution. The first peak is in young, active people, usually guys in their 20s or 30s doing sports. The second peak is in the elderly, usually from a simple fall. And here's a key fact to tuck away. It is the single most common fracture in all of childhood.
So how do they happen? Well, the classic story is a fall directly onto the point of the shoulder. Think of a cyclist going over the handlebars or a rugby player getting tackled. That force travels right along the clavicle, which is basically acting like a strut for the shoulder, and it just snaps at its weakest point.
Okay, so you've seen the patient, you know it's a clavicle fracture. Now you need to describe it properly. And the way we all speak the same language here is by using the Allman classification system. The best part? It's brilliantly simple. It's all about location, location, location.
Group I fractures are in the middle third, or the midshaft. And this is your absolute bread and butter. They make up a whopping 80% of all clavicle fractures. And it makes sense, right? The middle third is the thinnest part of the bone, and it doesn't have a lot of muscle or ligaments holding it together, so it's just the most vulnerable spot.
Next up, we've got Group 2, the distal fractures, out near the shoulder. These make up about 15%. Now for these, the whole game changes. The key question here, the thing that decides what we do next, is all about the corticoclavicular ligaments. If those ligaments are torn, that fracture is unstable, and that really pushes you towards a different treatment plan.
And finally, there are the rare ones. Group 3, the proximal fractures, right up against the sternum. These are less than 5%. Because this part of the bone is so well protected, if you see a fracture here, it means there was a ton of energy involved. This should be a huge red flag for you to start actively looking for other, much more serious injuries inside the chest.
Okay, so you've classified the break. Now you're at a crossroads. This brings us to the central debate in managing clavicle fractures. Do we treat them conservatively, or do we take the patient to theater?
On one hand, you have non-operative treatment. This is usually just a simple sling to keep the patient comfortable, and it works great for fractures that are still in a good position. On the other hand, you have surgery, most often with a plate and screws. And there are some absolute reasons you have to operate, and you've got to know these cold. An open fracture, any damage to the nerves or blood vessels, or if a sharp piece of bone is poking up and about to break through the skin, we call that skin tenting.
But what about that gray area? Let's zoom in on the most common and honestly the most controversial scenario. A completely displaced Allman group I fracture in a young, active adult. This is where the whole philosophy of treatment has really changed in the last 20 years.
And this leads us to the million-dollar question that has driven so much research. You see, historically, we just put almost all of these fractures in a sling. But over time, we started to realize that wasn't always giving patients the best results. So when is surgery actually the better choice?
And this chart, wow, it really tells the story. Just look at the difference in non-union rates. That's the fracture failing to heal. If you treat these displaced fractures without surgery, the non-union rate can be almost 15%. Now compare that to just over 1% with surgery. This single statistic is a massive reason why the pendulum has swung towards fixing these fractures.
So, in your exam, you can't just state an opinion. You've got to back it up with evidence. And thankfully, there are a few landmark studies and guidelines that have really defined our modern practice. Let's quickly break down the ones you need to know.
Okay, this slide is pure gold for your Viva. First, you've got Robinson and McQueen back in 2004. They're the ones who really identified the problem, showing that if the fracture was really displaced or in multiple pieces, the risk of it not healing was super high. Then came the game changer, the 2007 Canadian Orthopedic Trauma Society, or COTS trial. This was a head-to-head comparison, and it clearly showed that surgery led to better healing rates and faster recovery. And finally, the most recent AIOS guideline from 2023 kind of brings it all together. It says, yes, surgery gets you back on your feet faster, but a year or two down the line, the long-term outcomes are often pretty similar. So there's a trade-off.
All right, let's put all this theory into practice. Imagine you're in the hot seat. Here's a scenario that you could easily get in your exam.
So you've got a young, active patient, a mid-shaft break that's completely displaced and shortened, and no absolute red flags for surgery. This is the classic dilemma. This is where you have to show off your clinical reasoning. Okay, deep breath. What do you say?
Here is a perfect formula for your answer. First, summarize the case using the proper lingo. This is a displaced Allman group I fracture. Second, discuss the options. Show the examiner you know both are possible, but highlight the risks of non-operative care for this specific patient. Third, and this is where you really score points, you cite the evidence. Mention the COTS trial by name. And finally, state your recommendation clearly and tie it back to the patient. For this active cyclist, I'd recommend surgery to get them back to function sooner and lower their risk of non-union. It's a clear, safe, evidence-based answer.
And we'll end on this final thought, which is really the heart of the modern conversation about these fractures. It's not just about what the X-ray looks like anymore. It's about having a shared conversation with the patient, balancing the very real benefit of a faster recovery against the risks that come with any surgery. Understanding that nuance, that trade-off, that's what separates a good answer from a truly great one.